Hello and welcome to today's AAHAM webinar, the Certified Revenue Integrity Professional, or CRIP. At this point, it's my pleasure to introduce our speaker for today, Brenda Chambers. Brenda has over 30 years experience in the healthcare field. After nursing school, she obtained a business degree from Wayland Baptist University and obtained her master's degree in healthcare administration from Capella University. Brenda maintains several certifications, including the CRCEI, the CRCEP, the CRIP, the CRCS, and the FHFMA. Brenda has served on the Virginia State AAHAM Board since 2003, serving in positions of Treasurer, President, and Chairman of the Board. She presently serves as the Financial Chair for the state's chapter. In 2005, Brenda was selected to the Certification Chair's position on the National AAHAM Board and has served there for the past 11 years. Without further ado, I would now like to pass the floor over to Brenda.
Thank you. Hi, everyone. Welcome to today's webinar on the Certified Revenue Integrity Professional exam. The purpose of today's webinar is just to kind of explain to you what the CRIP exam is about and what it entails. So this is by no means any type of study session, but whether it's an informational session to let you know what it is that we're going to need to know when we go to take the exam. This is one of our newer exams for AAHAM, and a lot of work went into creating this manual and this exam. And I think that anyone who takes it will really know their revenue integrity information. They'll really know what it's going to take to show your professionalism in your field. So the first thing I wanted to tell you about is the purpose of the exam. The certification is really intended for anyone in the revenue cycle industry to help ensure that the facilities effectively manage their charge master, and that also any kind of documentation and billing is appropriate for any services that are rendered to a patient. It does require an in-depth working knowledge of the revenue cycle areas and the skill sets that are needed in order to make sure that you're getting properly reimbursed for your facility. In addition, it also ensures that the proper charging takes place to make sure and maintain compliance with all the insurance payer programs. So to give you a little bit of details about the CRIP, first of all, you must be a National AAHAM member to take the professional exam. Applicants must also have a minimum of a 2-year college or associate's degree or at least 2 years of healthcare experience. It's going to be very hard to pass this exam if you do not have some sort of knowledge of healthcare. The exam is 4 hours in length. It consists of 250 questions, which can either be multiple choice or true and false. The exam is broken down into 4 sections. In order to successfully pass the exam, you must get a 70% or greater on each section of the exam. Now, that's important to note, because if you get 3 of those sections that are greater than 70 and you get 1 that does not, you might get an overall score of, let's say, 75%, but your overall score does not count. What is going to count is the percentage you get for each section of the exam that you successfully pass. So beginning back in 2016, the exam is being offered 3 times a year, and it occurs in March, July, and November. So you will see listed on the slide, the applications have to be received by the national office for the March 2017 exam that will be coming up December 15th, 2016. The cost of the exam is $199. Each retake is $50. Now, you must pass at least 2 of the 4 sections in order to be eligible for a retake. If you do not, you have to retake the entire exam again if you wish to take that. So the CRIP does come with a study manual. You will basically get an outline that is part of your exam fee, but if you want the actual manual to study by, then you can purchase that from the national office. The The cost of the manual is $199 for members and $299 for non-members. However, if you cannot afford the cost of the manual, check with your local AAHAM organization or even call the national office or myself, and we will see if we can't do something to assist you. Most of the chapters of AAHAM has received a free manual to support their certification programs, so many chapters do loan that manual to individuals to study by as long as it's returned once the exam is over. So there are many reasons to take this certification, and one of the most important things is that it demonstrates a commitment to your healthcare profession, your career development, and it shows that you really possess the expertise and knowledge to meet the healthcare industry's highest standards. The CRIP can also assist with improving your earning potential. It can help you get recognition within the organization that you work for, and it also helps build a network of peers who shares the same designations as you, and that's always great when you need to reach out to someone for some assistance or some guidance or just to see how they're handling certain processes. Through continuing education units, you will continue to expand your knowledge and skill sets about revenue integrity. So the good thing about this, as long as you're a national member and you're maintaining your CEUs, you will never have to retake this exam. The CRIP is broken down into 4 sections. The 4 sections are the overall review of charge capture, ancillary services, surgical services and procedures, and our reoccurring outpatients and clinical services. So let's go ahead and we'll start this out by taking a look at the overall review of charge capture. So one of the things that the manual covers is the actual CDM. And when we're looking at the CDM, it's going to ask you things about what will happen if you fail to maintain an accurate CDM. How does it negatively impact the organization? Because, you know, we all know it could be from claim rejections, underpayments, overpayments, potential fines, penalties. But what it does do is it benefits us to have an accurate charge master because it can help minimize the billing errors, maintain compliance, support, order entry, consistent processes for patient charging, etc. The charge master actually drives more than 70% of an organization's revenue dollars because of its focus on outpatient services and supplies. The other thing that we will be taking a look at is the medical records. And medical record documentation is very important because we know that without proper documentation, it's very hard to support the charges that we are going to be billing for. So making sure there's a valid entry, a valid order, and the valid documentation is in the medical records that will assist us with not only the proper coding of the accounts, but it will also assist with making sure we're getting the highest reimbursement that we can possibly get from each of our payers. One of the other things that we talk about is the LCDs and NCDs and how important they are. Because, you know, your LCDs are your local coverage determinations and your NCDs are your national coverage determination. And they are policies or medical record review policies that are issued by MACs or CMSs to make sure that we are meeting medical necessity criteria for certain services we are performed. So you will have information about LCDs and NCDs on this exam. You will also have on the exam information about CPTs and HCPCS. Now, I can tell you, although there are HCPCS that are listed throughout the manual, you will not need to know those for the exam. They're in there as a guide and a reference, but they change. You know, every October, every January, you'll have your HCPCS or your CPTs changes. So with their constantly changing, it's kind of difficult to put them on the actual exam. So while it's in your manual as a reference, you do not need to memorize every single CPT HCPCS listed. It also discusses resource-based relative value scale, your RBRVS, and it talks about the fee schedule and your Medicare volume performance standards, the limits on the amount that non-participating physicians can charge. So it talks about your RVU, your relative value unit, which is your heart of your fee schedule, and what it is comprised of, the work required, the practice expense, and your malpractice insurance expense. Now, it does go into the UB04, your uniform billing, and this is important because in the manual it does list several codes. Now, the codes that are listed in the manuals are the codes that you're going to need to know as examples. So, if the condition code that I have listed is 17, which means the patient is homeless, then that's what you're going to need to know for the exam. I'm not going to give you a condition code that is not listed in the manual, so keep that in mind. There are multiple condition codes, occurrence codes, and value codes, and while it is important that you know them all, you do not need to know them all for the exam, only those that are listed in the manual. You will also see that we're going to be talking in the manual questions about MSDRGs and the significance of them. So your MSDRGs are your medical severity diagnosis related groups, and basically it talks about things that must be considered when determining if an outpatient service is subject to be bundled with inpatient admissions. And then it also talks about Part B billing services, etc. Now, modifiers are going to be very important as well, because modifiers will help determine if items should get additional reimbursement. So, that is the main importance of a modifier, is to make sure that you can get additional reimbursement based on services performed. A lot of times we do 2 items, services, when we're seeing patients, and sometimes that's questioned as to whether or not it's really needed. For instance, if we were to take a look at lab services and look at maybe a troponin level, we know if a patient comes in with chest pain, then normally there are several troponins that are drawn just to watch the levels and maintain those. The 25 modifier added to an E&M level, very significant to make sure you're getting paid for any of those evaluation and management services that are being performed. It does talk a little bit about modifier 50, for bilateral procedures, and 59, for distinct professional services. They did create 4 new modifiers, which are the XE, XF, XP, and XU. Those will be on the exam, so you will at least need to know the definition of those. Now, some facilities are using those. Most of them should. You have modifier 73 and 74, which is a discontinued outpatient procedure prior to anesthesia or after anesthesia. That's very important as well, because that can help impact your reimbursement. And there's some other modifiers that are listed, such as your 76 and 77. And one of the ones that you probably use quite a bit is also modifier 91, which is used to identify a repeat clinical diagnostic lab test. So you have to keep in mind that the modifier 91 should not be used when tests are rerun just to confirm the initial findings, or if, any other reason when a normal one-time reportable result is all that requires. You should not need it. But your 91 can be appended to certain things like, multiple, comprehensive metabolic panels, etc. The ABN is another item of discussion in the book, and it talks about the purpose and the proper issuance of the form. So we need to make sure, what the ABN is, what it serves, what its purpose is, and to make sure that, there are reasons Medicare will deny the service in reimbursement of the claim. And we need to make sure if they do that, we have an ABN for outpatient services on file that is valid so that we can then go to the patient and obtain the money for those services that were performed. So that's also very important. Under the ancillary services, we'll start off talking about some of the lab services that are there. Now, we know that with labs, there's different kinds of labs. We have independent labs, and we have clinical labs, and referring labs, etc. You're going to need to know those for the exam because hospitals should not submit separate bills for lab tests that are actually performed in different departments on the same day. So we have to keep that in mind. It talks about the data service for the lab policy, what the general rule is, what the variations. Sometimes there are exceptions to the data service. It talks about lab panels. There are a lot of lab panels. Some include your metabolic panel or your comprehensive metabolic panel, but you have a lot that occurs for lipid panels, OB panels, hepatic function panels. So those are some of those that you need to know. And then what is a reflex lab testing? Does your facility have one? What is it? Normally what happens with a reflex lab is some facilities have protocols that they have put in place where if a certain lab is going to be done, there's criteria that is used to identify any other type of diagnostic information that might deem to be appropriate for the patient. So there are required reflex tests and there's optionables. And they will go ahead and with required reflex tests, if you do a test and it comes back positive, the reflex testing protocol might say, well, then you need to run these additional tests as well. So that is something that is in the manual. With radiology services, the radiology services in the manual are broken down into multiple services that are performed. For instance, let's look at mammography. You have your screening mammographies, and then you have your diagnostic mammographies. And it talks about the criteria and the age group as to when you would qualify for one or the other. There's also a billing consideration for your mammographies because if you do a screening and a diagnostic mammogram on the same day, on the same patient, you can actually bill that with a modifier GG for reimbursement, and you can get reimbursed for that. Also, just so you know, for Medicare patients, a lot of times you will have a mammography screening performed on a male. CMS will not cover that. However, they will cover it if it is for a diagnostic mammogram. So if you should come across any edits for that, that will tell you the reason why. It talks about fluoroscopy and should you be charging it differently. Some of the CPT codes of services that are performed automatically have the fluoroscopy included in it. Some of them do not. Most of the time, if you have a service and the CPT description states that fluoroscopy is involved, then you cannot do a separate charge for fluoroscopy. So like you cannot use your 76001 CPT code. It talks a little bit about nuclear med, MRIs, sometimes with an implantable pacemaker. It talks about PET scans and, what is needed for the PET scan since it's really a non-invasive procedure that assesses perfusion and the levels of metabolic activity for various organs within the human body. So, that's important to understand as well. Now, with the pets, it does list some CPT codes and tracer codes, but that's just as a guidance for you as you're reviewing the manual for review of things within your own departments that are happening, or maybe you're having an issue that you're struggling with on how to get it paid or reimbursed. Also under ancillary services, we talk about medical nutritional therapy. Now, CMS does allow for medical nutritional therapy to be billed as long as it is furnished by a registered dietitian or some sort of professional who can meet the requirements that have been set forth. So there are, lots of benefits, which the manual talks about, and it also talks about the coverage guidelines as well. Now, in addition to that, there are a lot of screening services that Medicare covers. Now, this manual isn't all about Medicare, so I don't want you to think that we're specifically targeting in on Medicare, but what I do want you to know is that a lot of the services does center around CMS guidelines. So one of the things that is definitely covered is pap smear screenings, what the requirement is to meet a screening. It talks about pelvic exams and what the requirement is. PSAs, your prostate screening antigens for men, which just helps with the early detection of prostate cancer. Once again, that's another screening. Colorectal, a lot of screening services. Also, one of the things that is covered is vaccines. And so for vaccines, the manual covers things such as, pneumonia vaccines. It covers flu, hepatitis B vaccines. So those are items as well that is listed in the manual that you would have to study and know. Now, one of the big things a lot of hospitals struggle with or facilities is injections and infusions. And there's a pretty good detailed listing in the manual for the definition and the types of injections and infusions. So there are, several different types of injections and infusions, such as the initial service, the sequential administration, the concurrent administration. That's very important to know the difference between those three as well. It also goes in to talk a little bit about an IVP versus an IV infusion, and when one is done over the other, and what the difference between them means. Is it greater than 16 minutes? Is it greater than 30 minutes? Is it time-based? How are they broken down? They're actually broken down into 15, 30, and 60-minute rules usually. Then it talks about hydration versus infusion and when you should bill one for the other. It does give you some great examples of when to charge in here for things such as, chemotherapy infusions, any kind of therapeutic, diagnostic, or even prophylactic non-chemos. So great information to use. Now, one of the most important things in all of these items that are listed here in the CRIP manual is it has to be documented. That's one of the most important things you have to stress in order to get proper reimbursement for the services that is being performed. So, when documenting for injections and infusions, validating the number of IVs given, the rate change, the route, all the medications that were given intravenously, who inserted it, patient's vital signs, things like that, all should be listed in the medical records. pharmacy is a very important item under ancillary services. Now, as we know, a pharmacy, depending on the drug, we can have some very high dollar drugs. And it's very important that we have those documented, and we also have NDCs, if applicable, for any kind of Medicaid coverage as well. Understanding the status indicator K codes, they are separately reimbursed by Medicare, so we definitely need to make sure those are set up correctly in the CDM so you can get reimbursed for those. One of the important things with the pharmacy is the understanding of the single-dose vials versus the multi-dose vials. For instance, your single-dose vials, has to be used within 6 hours. With your multi-dose vials, it can be used up to 28 days. Your single-dose vials have to be billed for the dose administered plus any kind of wastage, where your multi-dose vial does not. And then you have to understand pharmacy wastage. When you have to discard the remaining of a single-dose vial and what kind of modifier you attach with those codes in order to get it billed and out the door. One of the important things with the pharmacy that you'll have to know is the understanding of pharmacy divisors or multipliers. So sometimes the way that the CPT code or the HCPCS code is set up is that, let's say it is a drug item for a 50 milligram vial, but if you go and you pull up that HCPCS code, it says that it is listed at 1 milligram. So if we gave 50 milligrams and it's listed at 1 milligram, in order to get reimbursed for each of those 50 milligrams, we're going to have to bill it as 50 units, and that's where your multiplier is going to come into effect to know that. So it's always very important to note, especially if it's a high-dollar pharmacy item reimbursable, that we have the correct multiplier set up for those items. And of course, it does go in talking about self-administered drugs, knowing what those are and the revenue codes that are associated with that. It talks about the NDCs, as important as they are and what they need as well. And then finally, in ancillary services, there is a section in there on dialysis, ESRD and non-ESRD, and when you should be charging, the G code and that sort of thing for dialysis. So, especially if it's an unscheduled or emergency dialysis treatment, how to bill and get reimbursed for those. And then sometimes we have instances where we have Epigen that is really administered to ESRD patients, and we have to report the hemoglobin and hematocrit as value codes on the UB04, and it talks about that and how you do that and why the revenue code 634 and 635 is important to distinguish the volume of the Epigen given, less than 10,000 units or greater than 10,000 units. One of the other things that we will go ahead and talk about as we reach into the surgical services and procedural section is going to be transplants. Now, not every facility has the ability to do transplants, but we really felt it was important to include this in our CRIP manual because it does occur broad-based. So while it might not occur at your individual facility, it does occur, and we felt that it was necessary to make sure we're including topics that will impact everybody. So some of the things you might find under your transplants would be kidney transplants and like the standard acquisition charges. What do you do with live donors versus cadaver owners? How you were to bill those. It also discusses items like heart transplants, liver transplants, stem cells. I mean, there's a big process of transplants in there and how to build them and what you should do, and that can be very difficult if you don't have a clear understanding, knowledge of transplant. So just to kind of have a little guidance, which the CRIP manual offers, is a great tool to just use. Under surgical services, it does go into talking about bariatric surgery and what the documentation should include for bariatric service. There is a national coverage determination that is done for the treatment of morbid obesity, so we need to make sure that the patient has met medical necessity so that we could get reimbursed from that. Inpatient-only procedures, that's very important as well, because if you have an inpatient-only procedure and you've sent the patient home, then how do you handle that? Are all the services provided on the same day? They must be billed as one outpatient claim, because it's not appropriate to bill an inpatient-only procedure on a separate outpatient claim if other services were provided on the same day as well, because they are considered as part of that inpatient-only procedure. Now, there is one exception to the inpatient-only rule, and that is if you append a CA modifier to the inpatient-only CPT code, you can get reimbursed only if the procedure was performed on an outpatient under emergency circumstances, or if the patient expires prior to being admitted after the procedure is performed. So let's just take a gunshot wound. We already know he's going to be admitted after surgery, and the doctor writes the admission order. If he was to expire before he would reach the floor, then you could add the CA modifier, and that would get reimbursed for you. But most of the time, you cannot bill an inpatient procedure on an outpatient account. It does talk about bedside procedures a little bit, what is considered the treatment room, and if a hospital routinely uses a patient's rooms to provide bedside procedures, the facility might want to start thinking about charging a higher room and board rate for those rooms than normally, just because they are doing some of those bedside procedures. So there are a lot of implants as well that we need to consider when we're looking at the charging. And one of the things that we need to take a look at is implants and the devices. So the FDA really defines an implant as a type of device that is intended to be implanted into a surgically or naturally formed cavity of the human body. So when we're going to do those implants, we need to make sure that we are billing all that we can. So we have to know how to handle those implants. We have to make sure that we are not only billing for the service, but we're also billing for the implant itself, because most of them are separately reimbursable, or they are a part of the package so that we can get reimbursed accordingly. Now, anesthesia is very important as well. Usually the technical component for anesthesia services is included in the anesthesia itself, but you will see the anesthesia fall on your UB04 with a revenue code of 370 with, of course, your leading 0. Most of the time, the 37X doesn't require a CPT or HCPCS. Now, I can tell you a lot of times with TRICARE payers, they do want to see that anesthesia code listed on the UB04. You can, under anesthesia, have your conscious sedation as well, and then, what is being done in the recovery room. For your no-cost devices, it usually, we can look at no-cost devices. We can take a look at replacement devices and, full credit. Do you get partial credit? How do you mark up? How do you bill that? What is the warranty credit? And, what modifier should be appended, etc. So we need to make sure that when we're capturing no-cost device information, that's going to be very important because we have to complete all of that information so we can make sure we're getting reimbursed appropriately. For cardiac catheterization, one of the things we do a lot of is cardiac caths at some of our facilities. And so it's very important that we make sure that we are billing for the appropriate cath. Is it a left heart cath? Is it a right heart cath? Did we do both a left heart and a right heart cath? What codes, CPT codes, are there for coronary artery catheterizations? Is it with a bypass graft angiography, or is it not? Is it lower extremities revascularization? Does it include road mapping, embolic protection, the use of arterial closure devices, etc.? Those things are listed in this manual for you to know and look at to help you with the overall reimbursement of the services that are being done. The documentation for the cardiac cath is very important, and that is because we have to make sure that documentation happens to list the devices or supplies that are used during the procedure, any kind of interventions that were performed, such as intravascular ultrasound, documentation of the access devices, any heart chambers that were entered. All of that really needs to be noted in the documentation of the cardiac cath because that will assist in the proper coding of the catheterization to make sure you get the highest reimbursement possible. Then under cardiac cath, it does talk a little bit about heparin. Now, you probably think that might be a little strange about being placed in the CRIP manual, but sometimes the detailed bill of the patient's records shows a cath lab charge for heparin. And sometimes that charge for heparin is just to bathe the catheter during the procedure. And that's usually routine because it's used to prevent any kind of blood clots from forming on the catheters or other wires. But in order for heparinized catheters to be charged, it has to be in the documentation to include the valid physician order and have it signed by the physician. And catheter bathe could be a protocol that might be listed, but it has to be there in order for you to get reimbursed for that. As we move on, we'll go to our very next and last section of the CRIP manual, and that is going to be our reoccurring outpatients and clinical services. The first thing we're going to be looking at for reoccurring outpatients is going to be rehabilitation services. So this is a lot of information on rehab services because we have to take a look at the rehabilitation treatment plan. And we look at the initial certification, which is, for usually about 90-day duration. And then we have to look at the recertification that has to take place if the certification has to extend past the initial. Now, as many of you probably know, there are a lot of functional G codes that have to be attached to the Always Therapy codes. So, for instance, you probably have heard of your GP modifier, which has to be attached to all of your 420 Rev codes, which indicate that the services are performed by a licensed physical therapist. Your GO modifier just says that it is performed by a licensed occupational therapist. That usually goes with your revenue codes 430. And then you have your GN modifier, which says that the service was performed by a licensed speech therapist, and that usually goes to all of your 440 Rev codes. Now, that's important to know because these are always therapy codes. A lot of facilities hard code those in the CDM, and that's perfectly acceptable. But each of the functional G code sets actually contains various things, such as the current status and what their projected coal status is, the discharge status of when they're going to be seen. Currently, there are around 42 functional G codes, and they are actually broken down into 14 sets of 3 types of codes. So you have your physical and occupational therapy codes, which are about 6 each, and then you have your speech therapy codes, which are about 8 codes each. So that's how those are broken down, and those have to be on the claim as well in order to get proper reimbursement for those. You might see a discussion on the KX modifier, which just indicates that the requirement specified in the medical policy has been met because, we have to bill for all the services. The service and the documentation has to be there. It has to have the functional information on the therapy claim notes. It also has to have documentation of all the G codes and severity modifiers that are being used for the appropriate therapy services. Now, with rehab, there is a guideline which is in the manual which will show you how to calculate the number of units to be billed, because any CPT code for rehab is done in about 15-minute increments if it's delivered on the same day. So, for instance, if you have spent less than 8 minutes for any of those services, you cannot bill for it. However, if you have billed 8 minutes to 22 minutes, you can bill for 1 unit of service. And so there's a whole guideline in the manual that says, this is the time I've spent, this is how many units I can bill for. Moving on to wound care, there are so many types of wound care services, and the manual highlights on majority of them. So the manual goes into talking about surgical debridement and what it includes. It talks about selective debridement, non-selective debridement, wound vac, HBO therapy, multi-layer compressions or any kind of Una boots. And what you definitely need to do, again, documentation is key. These are the things that you should make sure that is documented in the medical records to validate the services were performed, so you can code to the highest level of specificity and that you can get reimbursed for it. Same thing with your HBO. Documentation is going to be very key as we go through the wound care, since that is part of that. And then we'll hit up on observation services. So, of course, observation services really should not exceed, a 48-hour time period, really. But it's only covered when it is provided by an ordering physician and that it's reasonable and necessary. So when you're billing for observation services, there's really 2 types. There's a direct admit type where the patient comes directly in, from the physician's office into the facility, usually billed with like a GO379 HCPCS code, and then you actually have one where the patient might come in from the ER and is admitted to observation, or even after they've had a surgical procedure, and then that would be coded with like your GO378. Anything for observation services is always billed with the 0762 revenue code, and so that's important as well. So calculating observation hours is highlighted in this manual. The reason for that is it's very important to know that if there are certain services that a patient is being taken out of observation for treatment, then you can't charge for that. So, instance, patient is admitted to the room for observation services. Well, they decided during that they were going to pull the patient out, take him down to X-ray for whatever radiology service was ordered. Well, patient is out of that room. He's now receiving radiology services. He's no longer considered in the room for observation. So you have to carve those certain items out. That's all in the manual on how you do that. Also, making sure that you determine the correct end time of observation services. If the patient is discharged right after recovering from endoscopy, then, whatever time that recovering period in or that discharge time was ordered, that's what you need to use. Observation hours are usually rounded to the nearest hour, so 0 to 30 minutes of observation you really can't charge for. However, if it's 31 to 59 minutes, you can charge 1 unit of observation. So, it does talk about post-op observation orders, and it talks about composite APCs for observation, and that you can possibly get additional reimbursement for that. The other thing that it does talk about in the manual is your condition codes 44. Your condition code 44 is very important to know because it is basically a code on the UB that identifies conditions relating to a bill that may affect the payment processing of the claim. So usually condition code 44 was initially created to indicate that an inpatient admission order was changed to an outpatient status during the course of the stay. That particular condition code, however, can only be used on an outpatient claim when the physician actually ordered it, inpatient services, but changed his mind during the course of the stay. So there is a process that we must follow in order to use that and to identify that. That is listed in the manual. Now, one of the bigger things that a lot of facilities deal with is radiation oncology. Now, radiation oncology can be very difficult to bill and understand, so it's very important to understand some of the services that are performed and what they mean. Some of the terms you might hear during radiation services is, like a bite block, a bolus, a kilometer, dosimetry, the isodose plan, a wedge. These things would all be listed in their medical record documentation. So it's very important to understand what that means, and so when you see that, you know that those are services that you can be charging for. It also talks about, the treatment planning itself. It has to identify the location and the volume of the tumor that is found. Usually a one-time charge, but that should be listed in the record as well. Dosimetry, what is it? What does CMS define it as? How do you do those calculations? Those calculations are usually reviewed, signed, and dated by the physician when they go to do the services. So each of those various items are broken down so that you can see that, so you can know what they mean. Now, when we're talking about radiation oncology, there's a lot of treatment devices that take place. And so some of them that you might see listed as a charge might be a simple, an intermediate device, a complex device. An example of like a simple device would be like a hand block or a simple bolus. An intermediate would be like a T-bar or a breastboard or one of the bite blocks. But your complex ones will be ones that will say superflab, vacuplast, compensator, aquaplast. Those are listed in the manual so that you will know. And that definitely will help you when you're going to look at the documentation for radiation oncology. Also under radiation oncology, it talks a little bit about brachytherapy services, and it talks about the seeds and how to bill for those seeds. Finally, with your E&M level services, it talks about the definition and the guidelines about what E&M is. It talks about your Type A emergency rooms, your Type B emergency rooms, what the difference between the two are. Evaluation and management components are very important. There's 7 components based on that, and you will definitely need to know those. Even what is required in looking at those components as they are listed. Also, under your E&M, it talks about charging for emergency services, when you should be charging a level 1 E&M level versus a critical care component, or maybe a level 5. Also, it talks about trauma. It talks about when you need to activate trauma, what levels you should be assigning for any kind of OB patient, and whether or not you should or should not be charging for that. It talks about what will happen if a patient comes in multiple times into the emergency room on the same day. Can you bill it? Patient comes in at 6 in the morning, is discharged home, comes back at 8 o'clock that night, 2 visits, same day. Can you bill for that? It talks about that and how to do that. The other thing that it also talks about is your casting, your splinting. That's important to know whether or not you can or cannot bill. Everyone thinks that you can automatically bill for each of those items. It really depends on whether the item is fabricated versus non-fabricated. So understanding really custom versus non-custom items. One of the things that you can kind of keep in mind, fabricated, which splints, which can be charged, would be items like your, an elbow splint, a finger splint, any kind of your OCLs, your sugar tongue splints, a teardrop splint. If it's prefabricated, we cannot code. The charge is automatically encompassed in most of the E&M level charges, so we can't bill it separately. Those would be things that you would see like a wrist splint, a Velcro splint, some type of immobilizer or a post-op shoe, even a rib build is all considered prefabricated, and those are things that you cannot bill separately. So at this time, we'll go ahead and tell you a little bit about the manual and what you could find in the manual. You will see that throughout the manual, if you decide to purchase it, there are items in the manual which have checkpoints. And the checkpoints will look like you see there. Those are very important items to know. Like that one says the medical record documentation is the key to the proper payment reimbursement. Your knowledge boxes. Very important. Your knowledge boxes are there for a reason. They're telling you the difference between what an LCD and an NCD is. Those are throughout the manual, and those are very good guidelines in order to study. Also in the manual, under each section, you will have knowledge checks. So your knowledge checks will give you information on the items that were reviewed in the manual. It's simply questions for you to go ahead and answer. Once you have answered, it does go ahead and give you the answer as well on the following pages. So that gives you a good line item anyway, so you can follow up on those. Look for words that are bolded, very important in the manual. So when you go and you look at these words and you see the initiation, you see the reduction, termination, they're all bolded. That means these are ABN triggering events, by the way, that are listed. You're going to really need to know what they are, because that's going to be very important to understand the whole reason and purpose of the ABN. Make sure you know your differences. So when you're looking at the CRIP and you're trying to study for this exam, make sure you know the different types of injections and infusions. Make sure you know the difference between your initial service, your subsequential, your concurrent. Do you know when to charge for an IVP versus an infusion? When should a hydration versus an infusion even be charged? understanding your single dose versus your multi-dose vial, and make sure you know your differences in the modifiers that are listed there. Understanding the Type A and Type B emergency rooms, and understanding the custom versus the non-custom casting, splints, and strapping that we just recently talked about. Also, throughout the manual, you will have little trivia questions that are highlighted in the box. And so here's like a question that says the physician orders an IM injection. The nurse splits the dose and gives the patient half in the right thigh and the other half in the left thigh. Would you bill for one injection or two? So that would tell you what your answer is. So these are good guidelines and trivia questions to follow as well. There's also warning and notes throughout the manual. A warning just says that if the valid physician order and completed MAR cannot be located, then the charge should be removed from the account because it's not documented. We can't bill for something that is not documented. Also, as I mentioned earlier, the note, if the heparin is provided to be used to bathe the catheter as part of the procedure, there are no injection and infusion services provided. So therefore, the administration services for the medication for the heparin should not be billed, especially if it's part of bathing the catheter. However, if it is part of the protocol and a physician writes an order for bathing the catheter, then you can go ahead and do that. So at this point, this will conclude today's presentation. Do we want to open it up for questions, Michael?
Yes, we have a couple questions in the queue already.
Okay.
Our first question here says, I have a copy of the study manual from 2015. Does the material in the study manual change annually, or would the 15 manual properly prepare me for the exam?
The manual changes annually every year. However, you should be able to go to the National AAHAM website, and they should have an updated listing of the things that were changed from last year to this year. Anything that you will find on the upcoming CRIP is taken exactly out of the manual, so it will be whatever is included in the 2016 manual. So you can pull it from the website, or if you have any questions, you have my information right there on the thank you page. Send me an email. I'll be happy to go over that with you or talk to you about anything you might have, any questions.
Thank you. Our next question here says, they just wanted you to reiterate that they will only be tested on the information that's in the manual and that they will not need to know more than what is not in the manual.
Correct. So, for instance, on your UB04 codes, I'm not going to ask you what an occurrence code of 18 or 19 is because that's not listed. I'm not going to ask you questions about, PHP services for, provider hospital, partial hospitalizations or anything like that. It's not in the manual. There's nothing in the manual right now related to labor and delivery. So you will not be asked questions on that. So only what you see in the manual is what you should be tested on.
Great, and that does seem to be all the time that we have for today. So audience members, at this time, you should now see a survey live on your screen. If everyone could please take a moment to fill out this brief survey, AAHAM does appreciate your feedback. On behalf of AAHAM, I'd like to thank you all for joining us today, and I'd also like to thank Brenda for her excellent presentation. This does conclude today's session, and to end, you may simply hang up.